introduce my colleague, Dr. Aisha Al-Sharif from Saudi Kingdom, teach a distinguished neuromuscular expertise in King Faisal University Hospital. Please, Dr. Aisha.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank Prof. Sameh for organization of this meeting and inviting me to share this part of the meeting. Our speaker, which is my pleasure to present him, is Prof. Edward Kuppler. Prof. Edward is Professor of Neurology and Neuromuscular and Neuroimmunology and Sport Medicine, Sport Neurology. He is a Deputy Executive Director at King Faisal Specialty Hospital and Research Center, Jeddah. He's a member of several professional organizations, including American Association of Neuromuscular and Electrodiagnostic Medicine, Muscle Study Group, World Muscle Society. He's a very active speaker in the field of neuromuscular disease with several publications in the diagnosis and treatment of muscle and nerve disease. He's doing a great support in the field of neuromuscular disease disorder at Saudi Arabia. Also, his great support played a major role to establishing the Saudi chapter of neuromuscular disease. Thanks, Dr. Kuppler. Dr. Kuppler will present today an important topic, which is about the newer therapy for amyotrophic lateral sclerosis. So we'd like to welcome Dr. Kuppler.
Thank you, Doctor. First, I would like to thank Dr. Sama for inviting me to participate in this program. And what I plan to do is to talk about some recent updates in the treatment of amyotrophic lateral sclerosis. But before then, I just would like to share a little bit of the history of the disease. And we'll go back to this gentleman here on the left. And this is Bell. Bell was a Scottish physician and pathologist and surgeon. And he actually is the first one who described amyotrophic lateral sclerosis, at least in the pathologic literature. This is Bell from Bell's palsy. But what he also did is he identified the sensory and motor tracts. And in that context, he described ALS. Here on the right is Charcot. And Charcot is, to many, the father of neurology, and there are many diseases he described. ALS was one of them. Actually, in some countries, we still call ALS the disease of Charcot. In USA, though, we call it Lou Gehrig's disease, and Lou Gehrig was a baseball player who unfortunately came down with that disease. And this is his sharing of his diagnosis in 1939. And there's a video clip here, and I'd like to share it with you, and hopefully it works.
First baseman Lou Gehrig hung up an amazing mark by playing in 2,130 consecutive games. Then a fatal disease attacked baseball's Iron Man. In Yankee Stadium, touched to tears by the tribute, Gehrig made his last public appearance.
For the past 2 weeks, you've been reading about a bad brag. Today, I consider myself the luckiest man on the face of the earth. When you look around, wouldn't you consider it privilege to associate yourself with such a fine-looking man as is standing in uniform in this ballpark today? That I might have been given a bad break, but I've got an awful lot to live for. Thank you.
Actually, many people have come down with ALS. And this is just representative photos of particular types of people that have had ALS. We have actors, we have physicists, neurologists, football players, musicians, Olympiads, world leaders. ALS is global. And sadly, from the time of Lou Gehrig, we really haven't had much to offer patients except for hope. And what I hope to share with you is some of the things that are going on, and at least in some forms of ALS, we may have something more to offer in the near future. About, I don't know, 5-7 years ago, the people started trying to revitalize the ALS community, and we had the ALS ice bucket challenge, where people would dump the bucket of ice over their head in an effort to raise money for ALS, and a lot of money was raised. And sadly, as for many neurodegenerative disorders, we still haven't found that cure, although these funds supported people dramatically and still do. This is the typical phenotype of a patient with ALS. We've all seen this with bulbar and tongue atrophy, distal atrophy in the upper and lower extremities and fasciculations. And when you see it, it's just a horrible thing. It is the worst diagnosis I think that anybody could be given, because we really don't have a lot to offer. Pathologically, what we see is anterior horn cell degeneration, both in the lumbar spine and in the motor cortex, and that's illustrated here. This is normal lumbar spine, and this is lumbar spine from a patient with ALS, and you'll see a loss of anterior horn cells. These are anterior horn cells, and in this in this section, we don't really see much going on here. ALS is also a tauopathy, and what we do see in neurons is tau deposits, and this is TDP-43 immunohistochemistry, and we can see a lot of tau being deposited within those anterior horn cells. ALS is also a genetic disorder, and the first gene associated with ALS was Sod1, or superoxide dismutase, and that was very early on. And then over the years, we've seen a myriad of genes that have been associated that are either causal, permissive, or associated. And actually the two here are probably important, because gene therapies are being considered and attempted in both. And actually, I'll talk about those that have entered clinical trials in SOD1. The C9orf72 also has gene therapies that are starting. So when we see an ALS patient, we should think about symptom management, because there is a lot that we can do for symptoms that ALS patients have to improve their quality of life. But there's not directed therapies thus far that are dramatically effective. That said, by improving quality of life, it is valuable to patients, and they appreciate it very much. We've all seen those ALS patients that have excessive drooling, and this is very, very frustrating to them. Non-pharmacological management would be something like a suction device. However, pharmacologically, we can treat with either tricyclic depressants, anticholinergics, or Botox injections. And I think for me, when I've looked at it, it depends on accompanying symptoms. And if patients have pseudobulbar affect, then I would probably think of using tricyclic antidepressants, because that'll help patients with pseudobulbar affect as well. Otherwise, Botox is really effective, and you only have to do it a few times a year. Patients also have difficulty with thick secretions, and there are medications and nebulizers that really help loosen that up. Patients will have spasticity and a lot of jaw clenching, and again, this might be a symptom that botulism toxin injections would be very effective for. I've avoided baclofen and clonazepam because that causes hypotonia diffusely, and patients will notice a little bit of weakness when they're given those medications. Spasticity is a real issue in patients with ALS, and there are a lot of anti-spasticity medications available in paradigms. Again, the risk when you pharmacologically manage spasticity is unmasking weakness, and that makes it much more challenging for patients with ALS. So it's usually a discussion of an implementation of stretching and other physical therapy techniques to manage spasticity, rather than pharmacologically managing those. Of course, the real matter is respiratory issues and respiratory insufficiency. And with the advent of non-invasive positive pressure ventilation, patients have done dramatically well with either BiPAP or some similar PAP, and that's really been a game changer for patients with ALS. There are other matters, and I'll just go through one of these is weight loss or anorexia, and this is always a very serious sign in patients with ALS is when they start losing body weight. And in some cases, you may offer G-tube placement or medications to stimulate appetite. Feeding tubes are always a very difficult discussion, and what I always remind patients is they don't have to use them all the time, is they can still eat, but this would just offer a way to supplement their calories. And if push comes to shove, it can be removed, and patients somehow will accept it if they don't think that they have to keep it indefinitely. So we'll talk about medications now. There are 2 approved medications for ALS, and then I'll talk about 2 clinical trials. So the first and oldest medication is riluzole. Riluzole is a benzothiazole that has an inhibitory effect on glutamate release, and it causes inactivation of voltage-dependent sodium channels. This is very interesting, and when it came out, there was a lot of excitement or discussion because this works at excitatory amino acid receptors, which we think are cytotoxic in some cases. So the first publication of riluzole occurred in 1994, and it was a trial conducted by the French group. And they looked at a group of 155 outpatients with ALS, and it was a randomized controlled trial, and the outcome was either death or intubation. So we'll look at the results in a minute. Well, let's just do that now. These are the results. And so when you looked at all patients of the 155, those that were treated with riluzole did better across the board than those treated with placebo, and this is survival. When they did a subgroup analysis looking at bulbar onset disease versus limb onset disease, the effect seemed more prominent in those with bulbar onset disease, and it seemed much less prominent in limb onset. And there was a lot of discussion about this. And there was a cross-Atlantic discussion. This was a French drug, and a lot of hot tempers flew over this drug, and subsequently an additional trial was done. It showed basically the same thing, and riluzole achieved US FDA approval, and multiple other countries followed. There is a Cochrane review that was done by Bob Miller, and this was done in 2012. And as all Cochrane reviews, they look at all the literature, and basically what the outcome was is riluzole is reasonably safe and probably prolongs life by about 2 to 3 months in patient with ALS. Well, that's something, but of course everybody's been very frustrated, and a lot of people really don't use riluzole in patients because of this meager benefit. So here is what we have to do if we start riluzole. We give it on an empty stomach. And there's a recommendation to avoid barbecued foods because it will interfere with the absorption in some capacity. It's hepatically metabolized. People generally tolerate it well, although in some patients you'll have elevated liver enzymes, and you need to monitor that periodically. The cost in Saudi Arabia is about 54,000 Saudi riyals per year for this drug. So here we need to establish expectations, you know, and when you're treating a patient, they have to understand what to expect, or else if it doesn't happen what they expect, then they get frustrated. And so these are all of the different possibilities here. And with riluzole, what you should tell them is you're going to continue to worsen. You're not going to notice a difference, but it is going to give you, you know, a marginal increased life expectancy, and whatever wording you want to use for it. These other categories are really not there, and if you tell them they're going to improve and they don't, then they're going to get confused about that. So it's very important for them to understand in the beginning that they're going to continue to progress, especially with the cost involved. Depending on how they're obtaining drug, it's really not fair to say that they're going to stabilize or have some improvement, when this, in reality, patients should continue to worsen. So the second drug that has regulatory approval is edaravone. And edaravone is a very interesting drug. It's a free radical scavenger. And in the 80s, free radicals were a big deal. And in ALS, it was a big deal because of superoxide dismutase, you know, familial ALS in the early 90s, that became interesting. And so in the late 80s, this drug was developed as a treatment for stroke in Japan. So patients at that time, if you had a stroke, you thought if you would have a free radical scavenger like this or anything else, vitamin E, etc., that penumbra would be rescued or more rescued, and patients would have a better outcome. So this drug was approved for stroke therapy in 2001 in Japan. And it's really unclear. It was tried in ALS, and it was really unclear what mechanism it exerted. But I'll go through the studies with you. And really in Japan, it really wasn't a cost issue because it's an old drug and it's very low cost in the country. So this drug was studied, and the primary efficacy endpoint was a comparison of the change between treatment arms of the ALS Functional Rating Scale Revised. And this is in all studies now, so I thought I'd share it with you. And so what the ALS Functional Rating Scale shows are different aspects of ALS. They look at bulbar symptoms, and they break that down into speech, salivation, and swallowing, fine motor movements, gross motor movements, and respiratory issues. And so you're scored based on whatever, you know, whatever it is. Actually, a patient can fill out this score. It's really easy. And then differences are looked at from baseline to the end of the study. And if there's improvement or deterioration, it depends on the score. So there was an initial phase 2 study in Japan in 2006. It was open label, 20 subjects, and it was dose finding, and 15 were on 60 milligrams. And I failed to mention that edaravone is a IV medication. And patients were treated for 14 days, followed by 2-week observation, and this was repeated for the next six months. And the primary endpoint was the change in the ALS Functional Rating Scale score. And the secondary endpoint was the change in 3-nitrotyrosine levels in CSF. And what 3-nitrotyrosine is a marker for oxidative stress, and interestingly, in the patients that were treated, this marker almost became undetectable at 6 months, and so this excited the investigators and allowed them to push forward with a confirmatory study. Although it took a long time to do it because the confirmatory study was much later. 246 patients were enrolled, although only 206 were randomized, and it was a 1-to-1 randomization paradigm with patients being given either placebo or Endeavorone. And patients were treated for 14 days IV and then observed for 14 days. And then cycles 2 through 6 changed a little bit, 10 days on and 14 days off. And then they analyzed the outcomes of the study. And this is what happened. And what we look at here is change of the ALS functional rating score. And what you see in patients with ALS is not much difference here. So what this did is it led to a third study, a 6-month randomized placebo-controlled study of 137 patients with ALS who were living independently. And these patients were very early on in their disease and had very mild symptoms. They all had normal respiratory function. They retained most of their activities of daily living, and a similar paradigm was in place, looking at the change in the ALS functional rating scale after 24 weeks of therapy. And with this study, on these early on patients, we saw here a benefit for treatment. Based on this study, there was US FDA approval of Endeavorone. And this is a IV medication. It's 60 milligrams over 60 minutes. And the initial therapy cycle is 14 days on, followed by 14 days off. And subsequently is 10 days on and 14 days off. There are some allergic reactions that have occurred with this because this contains sodium bisulfate. It's really sulfa allergies that occur. But the cost is really high. It's over 500,000 Saudi riyals per year plus infusion cost. And really, it's really time consuming for patients. They spend, if they were going to spend a year on this drug, it would be 124 infusion days per year. And it's really about a third of the year. So the 3 studies did undergo a meta-analysis, and this is published. And basically, what was stated was that there was a better outcome when you're looking at ALS functional rating scores at 24 weeks, but mortality was not affected by this therapy. The 3 studies, though, did exhibit heterogeneity, and that has to be taken into effect. But it's very unfortunate that such a cost, a high cost drug, not only with financial cost, but time. The mortality doesn't really differ, but the functional decline was a little less rapid. So if you're treating someone with Endeavorone, again, we have these same 5 categories to discuss, but unfortunately, we have to tell the patient they're really going to continue to worsen, but it's going to be at a slower rate. And none of these other possibilities are shown by an evidence-based practice thus far. And it's not a surprise. Here we have everything that's going on, in the anterior horn cell here, and what's shown here are the places that riluzole affects and Endeavorone affects, and you can see these red or green T's, and you can see that there's some actions that are affected, but there are many other processes that are still occurring and are not affected by either of these. And to my knowledge, there hasn't been a combined study to see if using these both together are synergistic. And so I think it shouldn't be a surprise with such a complicated medication or a complicated disorder that a single medication isn't going to resolve the problem. if we look at these side by side, riluzole is a glutamate antagonist, and deverone is a free radical scavenger. One is oral, one is IV. Riluzole, the old fellow on the block, does increase life expectancy, and I apologize, I just noticed the spelling error, to 2 to 3 months. And deverone decreases the rate of progression, but thus far doesn't have a clear effect on life expectancy. And the cost is very different and very high. So if we look to the future, there are 2 trials that I'll share with you, and then I'll stop. I think I'll be out of time by then. And this is in SOD1 related ALS. And the first trial I'll talk about is an antisense oligonucleotide that was infused into patients intrathecally with SOD1 mutations. And the medication is called tofersen, and the paradigm is very similar to that used for spinal muscular atrophy. The study was a phase 1/2, so the primary outcome is safety. It's 50 people, and they were divided equally into 5 groups: placebo or dosing of 20, 40, 60, or 100 milligrams. And then they received 5 doses of the drug. And then, even though it was a safety-based study, they did look for outcomes as well. So let's just look at what happens in SOD1 ALS. So we all have SOD1, or superoxide dismutase genes, within us, and we all produce a protein that acts on oxygen radicals. But unfortunately, in patients with SOD1 associated ALS, they have an aberrant protein, and this protein is not fully functional. What happens is that when this protein is developed and is not able to deal with these reactive oxygen species, then we have motor neuron degeneration. And so the idea is if we could create an antisense oligonucleotide that would allow increased amounts of normal appearing superoxide dismutase, or at least less of the abnormal protein to be accumulated, then there may be a therapeutic effect. So that's what tofersen is. It's an antisense oligonucleotide, and this is the safety data for the patients, and this is based on the study paradigm, and patients again had 5 doses, and so CSF analysis was done at each. And what was found is there were 4 patients that had CSF pleocytosis, and I think one or several actually had increased CSF protein, but it was really transient, and it didn't really lead to any harm. And that was really the majority of the serious adverse events that occurred that were attributed to the medication. So additionally, one of the outcomes that looked at was SOD1 concentration, and what you can see here is that the mutant concentration decreased with the increasing amounts of tofersen. So that was very interesting, and that was a direct marker of efficacy. Also, functional scales were looked at, of course, both muscle strength as well as respiratory function, and these are at the various points in time. And what you can see is that patients with placebo progressed, but those on medication really didn't progress as quickly. And I'll show it to you here. This is looking at the whole group together, and you can see the blue is the placebo and the other colors are the treated. And so you can see in all categories that patients who were treated either stabilized or did better than those who were in the placebo arm. On the left, it shows individuals, and I thought that was important is because it does even show some placebo patients who stabilized, and I always think that's important to remind us that you know, when we're looking at a single patient, whatever their outcome is, it's just a single patient, and we don't know, you know, if that's a placebo response, because we can see easily in a lot of these patients, they stabilized for the duration that were on placebo. This was the phase 1/2, and actually the phase 3 study is now underway for this particular medication. The last one that I'll talk about is Sod1 suppression using a gene therapy construct in patients also with Sod1 associated familial ALS, and this is using an adeno-associated viral vector, again delivered intrathecally. And Bob Brown and his group in Massachusetts did this. There were only 2 patients studied, and so we can look at those 2 patients in depth. So this is the 2 patients here. One is the Sod1 patient that was very rapidly progressive, and he died. And the second one was also an Sod1 patient, but with a different mutation, and he was stable beforehand, and he stabilized afterwards. And at the time of the publication, which was May of 2020, the patient was still alive. The patient that died did agree to a post-mortem, and this is his anterior horn cells in his lumbar spine, and he did have a very strong, one of his legs was very strong, his right leg, and you can see here that there was increased amounts of anterior horn cell or motor neuron survival compared to the other side. So patients, these 2 patients were treated, and this is the first patient, and so this is his strength, and he did notice transient improvement in his strength, and then it continued to decline, and he died at 60 months. Excuse me. He also did have a B and T cell reactivity, and he had a reaction to the construct. So that's why he was treated with methylprednisolone. He was actually treated, and he stayed on prednisone for a long duration of the trial, and that's the reason for that. This patient did have protein analysis in the cord done, and so this is the patient. These are control patients and healthy controls, and what they're looking at is native SOD1 or normal appearing SOD1 protein in spinal cords, and in the patient, you can see after he underwent therapy, he had the SOD1 protein decrease. And we have to remember this SOD1 mutant protein is toxic, and this occurred both in the lumbar cord and in the cervical cord, and that was robust compared to both healthy and diseased controls. There was also a look at enzyme activity, and this would be normal activity, and so what you can see is in the patient there was a lower enzyme activity than in patients who were untreated. So that's what I have to share with you. We've talked about the various approved therapies for amyotrophic lateral sclerosis, those being riluzole and endeavorone, and then the potential gene therapy or antisense oligonucleotide therapy for SOD1 related ALS. And what's the excitement right now is that others are on the way. So hopefully within a few years we'll have something a little bit more to offer our patients than we do now, and that they certainly than they had in the late 30s when Lou Gehrig suffered this disease and set the ball in motion. Thank you so much.
Thank you, Dr. Kuppler, for this nice talk and giving this poor patient hope in the near future for gene therapy.